Good afternoon, everybody, and welcome to this episode of Humanities Cafe. Today, we're going to talk about medical debt. Kind of to introduce you to the subject itself, 80% of Americans have some sort of debt, right? Whether that's credit cards, car loans, mortgages, student loans. But 41% of American adults have medical debt. That's over 100 million people. But unlike student loans or mortgages or car loans, medical debt isn't something that people get to choose, right, or opt into. In fact, 2/3 of medical debts are the reason of a result of a one-time or a short-term medical expense arising from an acute condition, like you get appendicitis, or you get in a car accident, or you slip and fall. So rarely is it planned, and consumers don't have the opportunity to shop around for medical care. So while being number one in the nation is usually something to be celebrated, that's not the case for what we're talking about today, medical debt. South Dakota leads the nation in this phenomenon. So joining us today to talk about this issue are two professionals who are experts in their fields. We have Dr. Axton Betz-Hamilton and Dr. Tom Dean. And before we dig in and unpack the issue today, I'd like them to tell us a little bit about themselves and their interest and background in this area. Axton, you want to go first?
Sure. My name is Axton Betz-Hamilton, and I'm an associate professor in the Ness School of Management and Economics at South Dakota State University. I teach financial counseling and planning courses here at SDSU, and much of my research focuses on financial abuse within families. Certainly, debt and medical debt can be a part of that.
Dr. Tom, you're up.
Hi, I'm Tom Dean. I'm a retired family medicine physician, practiced in Washington Springs for 43 years before I retired a couple years ago. I've had a lifelong interest in health policy and been involved in a variety of, I was past president of the National Rural Health Association and a variety of organizations that have been active in public policy issues, as well as I mentioned, I spent some time with a group called the Medicare Payment Advisory Commission, which is a branch of Congress that advises on Medicare policy. So it's been a long-term interest in mine, and also I've had plenty of personal experience. I'm a cancer survivor and have benefited from some very expensive drugs. So I have been able to look at it from that perspective as well. So I'm really concerned because I think we are just not handling the financing or the distribution of healthcare in a way that really serves our people.
Thank you for those introductions. So to start off the conversation, in a nutshell, what does medical debt mean? What is medical debt?
You want to take that, Tom?
Go ahead.
Okay. So medical debt is essentially debt that results from care that you receive from any medical provider due to an accident, due to an illness, and maybe due to a mental health condition as well. And it's debt that results from charges that perhaps your insurance provider doesn't pay, and that's due to the provisions that are in your specific plan document, and you have to cover that proportionate share of those costs. Unfortunately, a lot of folks are not prepared to cover those costs, particularly when there is a significant medical event.
Well, and included along with that is the cost of prescriptions. Sometimes if you have to use your credit card to pay for a prescription, that credit card debt counts as medical debt too, right?
Yes.
Okay. So when I was digging into this topic, I was a little bit disturbed by the statistics that I found. So nationwide, 15 million Americans have medical bills on their credit reports in the amount of more than $49 billion in collection. That's a lot of money. And average medical balance on credit reports increased from $2,000 to $3,100 from 22 to 23. And health status and income are the key factors in an increased amount of medical debt. So breaking those statistics down in a nutshell, what's going on across the nation?
I would just add to the statistics. I don't know just recently, but over the last few years, medical debt has also been the #1 cause of personal bankruptcy.
Is that nationwide, Dr. Tom?
I think so. Like I say, I haven't dug into the data just recently, but it has been, yes.
So,
I'm not familiar with South Dakota's experience, but I suspect it's not different.
oh, sure. Well, yeah, because when the statistics for South Dakota, nearly 18% of South Dakota adults have medical debt, highest in the nation. The national average, if you want to like compare it, the national average is 8.6%. So we're more than double of the national average, and we're almost lapping, you know, all the other competitors because Mississippi is second with 15%. So we're really exceeding in this area. Why are the rates so high here? Dr. Tom, this is your expertise area. I know it is. I have read your columns, and I appreciate that you're joining us because you know how to explain it. Why are rates so high in South Dakota?
It's a difficult issue because it can become exceedingly complex very rapidly. But I think the fundamental issue is that we have chosen to distribute healthcare the same way we distribute other commodities, namely that we have individual providers that charge what they think they need to, and people can move from one source to another. But with medical services, there is really no incentive on the part of providers to limit those costs. And in fact, there is probably some disincentive because there have been studies that show that some members of the public, and probably quite a few, if a healthcare provider advertises that they have the lowest cost care, the immediate assumption is they must be cutting corners and it must be second-rate care. And so we have in a classic market system, the competition is the thing that brings down costs. But in healthcare, we have a classic example. We have probably the most clear-cut example of true competition. I don't know of any place in the country where there is where it is as clearly head-to-head competition as in Sioux Falls. We have two very reputable systems that compete, but the problem is they don't compete on cost. They compete on who has the most elaborate facilities, who has the most sophisticated specialists, who has the greatest range of services. And so in that sense, competition can actually drive up costs. It actually works in reverse. And so that's kind of an overly simplistic overview of the situation. Well, I guess I'll stop there.
Well, and statistically, South Dakota is the second most expensive in the nation for healthcare behind North Carolina. We've experienced a 308% increase in the per capita cost of healthcare in the past 25 years, with a 30% increase in just the past 5 years. So if to put it in dollar amounts, overall spending on healthcare nearly doubled from $633 million in 2010 to $1.12 billion in 2020. That's like when we think about our population is not that big. That's a lot of money. So that there's a number of different contributing factors too. And to break it down further, the administrative costs and the billing procedures. Can we break that down a little bit? What are administrative costs and billing complications?
They're a huge element of our overall costs, and that is a major issue. The experts that have tried to analyze this believe that somewhere in the range of 25 to 30% of the costs of healthcare go to pure administration, and that has evolved from multiple payers, and so each provider, be it individual physicians or hospitals or whatever, have to deal with a whole multitude of different sets of rules, and they have to in order to justify the charges that they're sending to their, whether it be an insurance company or an individual or whatever. And so though that means that the administrative requirements are huge. And there was a very interesting study a few years ago where they compared the administrative costs for a physician's practice in the United States compared to a physician's practice in Canada, where they only have one payer. And the result, and of course, these are overly simplistic because there's a lot of variation across the country, but the net result was that the costs for US physicians was 4 times higher than it was for Canadian physicians. And who, like I say, deal, they get mad at they have to argue with their payer, which is the government, just like all the physicians here. But they only have one devil to deal with. We have a multitude of devils to deal with when it comes to trying to collect payment for services.
And another piece is the overhead costs and employee shortages. Now, back in December, we on Humanities Cafe, if some of you were able to join us then, we talked about the rural and reservation healthcare crisis in South Dakota. And when I think about the staffing shortages, you don't think that would contribute necessarily to the high costs, but I kind of think of it as when you have John, who's a nurse in a rural hospital, they have a shortage there. So he's working 20 hours of overtime every week. And at $40 an hour, his regular rate, and then you put that time and a half, I mean, that also increases the cost, right? And then the overhead of keeping a rural hospital or health facility open is also pretty high, isn't it?
The other part of that is there are a variety of traveling nurse services and other providers. I'm on the board of our local nursing home, and they have had a terrible time recruiting nurses and nurses' aides, and so they are almost continually paying for these out-of-state services to provide individuals, and they get reasonable people. I mean, they get the providers that they or the caregivers that they need, but it's at a huge cost, way more than they would ordinarily pay if they were hiring them directly.
Right. And what part does the ever increasing cost of drug prices have to do with the high medical costs? I mean, it seems kind of obvious, but are you familiar of any policies or anything, inner workings that are causing the prescription prices just regularly increase? And Dr. Tom and I had this discussion the other day, that it seems like medications that are necessary to stay alive are the ones that cost the most. And it just, how did we get here?
Well, my bias is that it's a absolute failure of a market system. We supposedly have some competition between these companies, and yet it doesn't seem to work effectively. For instance, there are 3 different companies that manufacture insulin. And basically they have different names and so forth, but basically they produce the same product. And yet our costs for insulin over the last few years just went steadily up. And people who were paying $100, $120, $150 a month for a supply of insulin could go to Canada and buy exactly the same stuff for $20. And that was when the government basically stepped in and said, at least for Medicare recipients, we're going to put a price cap on that at $35. And I have said that I believe in the free market, and I believe that capitalism has served us well in many areas, but it has failed in this area. And so I have said the behavior of the pharmaceutical companies, they are begging for price controls. And that is, in fact, what they got, at least in the range of insulin. And it's whether it, I can give you my own personal experience. I have multiple myeloma, which is a bone marrow cancer. I'm very fortunate. The drug that was new when I was diagnosed about 15 years ago started out at $8,500 a month, and that seemed absolutely outrageous. By this last year, when a generic became available, it was up to $17,000 a month, and so people say, well, maybe we'll get a generic. Well, we did get a generic, but generic companies aren't stupid. They're not going to price that at $100 a month. They price theirs at $11,000 a month. So anyway, it just the basic market principles of competition controlling prices just simply hasn't worked. Maybe from an economist's point of view, there's a better perspective on that. I don't know.
No, I think you're spot on. And you bring up a really great point that, supply and demand works well in many, many, many other markets with regard to controlling prices, and it's not working in the healthcare system.
Well, and another piece of the puzzle for the high medical costs, of course, technological advancements come into play, right? So you got to have the new equipment, you got to have the good stuff. And I think back to what you were speaking about, Dr. Tom, about the issue with competition, where competition you would think that instead of a doctor at facility A saying, okay, facility B has somebody who can really, they have some great stuff over there that they could use to help you. Instead of referring it to the competition, they're going to build their own. So it's that whole piece of, we got to have our piece of the pie. And so the competition is not conducive with collaboration, and definitely not in the best interest of the patient, right?
That's exactly what's happened, I see, in Sioux Falls. I mean, I have a lot of friends in Sioux Falls. I think basically healthcare in Sioux Falls is at a fairly high quality, but they have duplicated everything. And instead of having one kidney transplant service, they've got two, and they got two heart hospitals. We got two helicopter systems. We got and where some of these things not only increase the cost, but on some of the really highly technical procedures, the higher the volume, the better the outcomes, because you develop the procedures and the staff familiar. And so instead of two small systems are likely to have poorer outcomes than one big system. But again, this competition issue works against us.
Apparently, yeah. And then another big piece, in addition to the high medical costs, I want to just take a quick look at insurance's role in this whole issue. Statistically, there's a huge lack of insurance, I shouldn't say huge. It's not huge anymore. Lack of insurance or insufficient coverage. 62% of South Dakotans have employer-sponsored healthcare, right? But that rate is only 19% for Native Americans, and that's the lowest in the nation. There's high deductibles, there's co-pays, there's co-insurance. Those are kind of, they're insurance words, right? But they play a huge role in why our medical debt is so high. Especially those with chronic illness, right? They experience a number of co-pays, a number of different co-insurance payments, and those add up quickly. So and I know that, like, your experience with Medicare, Dr. Tom, what's the solution with the insurance situation? And medical billing is another piece of that.
I kind of chuckled because if I had a solution, I might be famous. I don't know.
We could make that happen,
It is just an exceedingly complex problem, and the problem is that, or one problem, shouldn't say the problem, is that there are a lot of elements of the healthcare system that are doing just fine and actually making a lot of money. And, you know, some medical providers are making a lot of money, health insurance companies are making a lot of money. And so when you are proposing more radical shifts in or structures in how we organize this, there are some powerful lobbies. I mean, I just read this morning how much the pharmaceutical industry has spent, even just in the in 2025, and it was in the billions in lobbying. And so they're a powerful force in the political realm, and they're just defending their turf, which right now they're doing quite well, and so they're not about to back down. And so, well, anyway, it's intimidating, but it's serious enough that we really need some fairly aggressive response.
I want to take a break here. There's some comments and questions in the chat, and I'm going to read those to you. Joseph has a question. He says, is there also an issue with regionalization in the western side of South Dakota with Monument Health, and in the east, a duopoly of Stanford and Varick dictating policy? Is that one key to the issue of medical debt in South Dakota? And Joseph, if you feel like elaborating on your question, by all means, please do so.
I don't really have a good answer to that. I mean, on one hand, medical or healthcare has become so complex that it almost requires these large systems to have all the expertise that you need to manage it, and especially to afford the technology. The problem, if you know, we touched on this a little while ago, we're probably not using this technology efficiently, because ideally, if you have a very expensive piece of technology, hopefully you would share it and use it to its maximum. But we're not doing that, and the current financing system doesn't reward those kind of decisions. So I don't know if that probably doesn't answer the question at all. I don't know. You know, I think that, like I said, I think the two systems in Sioux Falls, from what little bit I know about the monument system, they're very reputable systems. They give good care, but the way it gets paid for is troublesome.
I wanted to share a couple of comments too. One of the comments is all the insurance companies are in bed together, not providing competition to benefit us consumers, but to brainstorm together but they need to brainstorm together for ways to get richer and richer, or need to. I got a little blurb on my thing here. They brainstorm together for ways to get richer and richer together. And I think that goes along kind of with what we've been talking about. Mary says the competition should prioritize the health and well-being of people instead of focusing solely on profit. Exactly. And Trish says, my primary job responsibilities are working with insurance, and so many or most patients have little to no understanding of how insurance works and what those insurance terms mean. Absolutely. For example, just because your policy covers chiropractic services, that doesn't mean that your insurance will be totally paying all the charges. I.e. they may need to meet their huge deductible first, and so many average Joes do not understand what that even means to them. And that's one of the things that I mentioned with the cost sharing piece of that there's a lot of people who don't understand what co-insurance, and when you mention it, it just shuts down. Okay, never whatever. It is whatever. But Trish is spot on. I think a lot of people think that because you have insurance, that means it's going to cover everything. No. Full disclosure, 4 years ago tomorrow, I had a heart attack. And I ended up I was in intensive care for 5 days. I had 3 heart surgeries that year, one being a quadruple bypass, so intensive care for another week. I was kind of shocked and scared at the close to $1 million bill for that year. Luckily, I had insurance, and you know, there's the out-of-pocket maximum that comes into play. But if you don't have that benefit of really good health insurance, what do you do? Even with insurance, you know, okay, here's your deductible. You met your deductible, but then you have your copay, and then you have the coinsurance, and all of that until you meet your out-of-pocket maximum. There's just so many things to think about that are so confusing. And Trish adds, it makes it hard for those average Joes to have a voice to fight the system. Absolutely. So does anybody else real quick have any questions, any other questions you want to throw out there?
I can certainly comment too. I worked in the 2019 was when I left the medical billing field as well, as far as that goes, and talking about the insurance part of that, and that some facilities, like right around that time, Sanford decided not to accept Avera, insurance, and likewise the other way, Avera not accept Sanford, and for regional, and talking about that and the availability of a lot of the facilities, you either had to travel to that or just pay, because your insurance wasn't going to cover that, and where a lot of us are rural wise and having to travel, and then the locations, like you said, Dr. Tom, as well, about the two entities having the same things was maybe because of that too, because of, not covering it. If you had to go and be flown out from Avera, you'd have to be flown out from Sanford if you had Sanford insurance type of a situation. But there is such a high burnout, and talking about not only the providers, but also in those aspects, and what you deal with, and all the different insurance companies billing differently or what they accept, and then having to work through the patient's billing or fight on their behalf. And I don't think a lot is spoken enough of the financial assistance applications that are also available at the different facilities, that maybe patients aren't aware of that, or us as South Dakotans are, very, very proud, and we don't want to ask for help too, and so then in turn go into that debt. So, but I think that that's something that needs to be published more too, for those that are struggling to get through that paperwork, whether you need to ask for help sitting down to fill them out, or just getting them, period, to help out, because it is very beneficial. And whether it takes a percentage off your bill or you work out payment plans, that's also something to assist with going forward for South Dakotans too, to be aware of those.
Thank you, Tara. So I want to, now that we've discussed the basics, right? Let's talk about consequences. It probably goes without saying there's consequences to having medical debt, right? But there's not just the financial problems. I mean, the financial problems, with the debt collection, wage or bank account garnishment, things like that. What else is there, Axton? I know this is in your wheelhouse, so I'm gonna throw it out to you. What are some of the consequences of unpaid medical debt?
Oh, we already hit on some of them, of course, but one common consequence that folks don't necessarily think of is damage to your credit score. So if you have unpaid medical debt, you can't afford to pay it. Maybe you're feeling ashamed of asking for financial assistance from the hospital or the healthcare provider, and totally understandable. That's, it's very common. And so it gets to the point where you've ignored it. You maybe don't know what to do about it. And it gets turned over to collection. And that will pull down your credit score. And debt collectors do have the right, as well as original creditors, so the hospital or healthcare provider, do have the right to file suit against you to recoup those losses. And so that can also show up on your credit report as a judgment. So the collection account will show as a negative credit account. If they file suit against you and obtain a judgment, that will also show as a financial judgment on your credit report, pulling down your credit score, which can make it difficult to obtain loans and housing. It can make your auto insurance rates go up. So our credit score is one factor that is used in determining our auto insurance rates. It really can just create a ripple effect of financial problems that go beyond the scope of just the medical debt.
Well, and then the interest on the existing debt makes it even bigger,
Mhm.
right? And then
Right.
there's bankruptcy. I mean, and, you know, it seems like some people might say, oh, it's, you know, it is what it is, but there's bankruptcy, there's potential homelessness involved here. When you think about, you know, what can be taken over, you know, when you file bankruptcy. Um, Another piece of that is the health problems. So it seems counterintuitive in some ways, but if you have a health condition and you know that you already have medical debt, are you going to want to compound your medical debt by going to the doctor? So a lot of people, and I'm sure you've experienced this in your practice, Dr. Tom, a lot of people avoid going to the doctor because they don't want the debt, but then that just makes them sicker, right?
Yeah, yeah, that clearly happens. It People are partly they put it off because they think, oh well, it'll get better. But partly, you know, the costs are an issue for people that either don't have any insurance or don't have insurance that covers those sorts of primary care services or whatever. Yeah, no, it's a real issue, and there's been studies that show that it contributes to poorer outcomes if you put off. And one of the most alarming bits of data that I am really concerned about is maternal mortality rate.
Mhm.
Is the maternal mortality rate, meaning women dying in association with childbirth in the US, is one of the highest in among developed countries, and it has gotten worse. And part of it is that there are, again, it's a complex issue, but the some of it has been people not seeking out prenatal care or not following up with care after the baby is born, and not dealing with either underlying health conditions or new health conditions. And uh, uh, well, it's just a really disturbing statistic, even though the numbers compared to heart disease, the numbers are fairly small, but still, these are totally preventable deaths, or at least the statistics are 70–80% of them are preventable if people have adequate care, and they're just not getting adequate care. And you know, a lot of that has to do with the finances, I think.
Absolutely. That's what I've been finding in the research that I've been doing, because there's also the issue of increased stress, right? You have this debt, it stresses you out, and it just gets worse, which is also then in turn more detrimental to your physical and mental health. So it's just a compounding factor where it just accumulates. Um, so there is a question in the chat. We're gonna address it in the discussion first before I read off the question, but there's been some things done legally, right, or legislatively to address the issue of medical debt. So federal law does exist that requires healthcare providers to establish and publicize a written financial assistance policy, but this law lacks any minimum eligibility requirements and leaves it up to the states to fill this gap. So the only way to enforce federal financial assistance requirements is to threaten a hospital's nonprofit status, and the IRS doesn't want to do that. So according to some statistics I want to toss out there from Georgetown University's Health Policy Institute, I was a little disappointed, maybe a little bit shocked with South Dakota, where we stand in relation to that federal law. South Dakota has no statutory or regulatory financial assistance requirement for hospitals. We have no requirement for hospitals to make payment plans available. We have no preconditions before a hospital can send a bill to collections. 14 states do have that. Minnesota prohibits it completely. In Minnesota, the hospitals cannot send your medical bills to collection. We have no requirements or preconditions at all. And South Dakota does not limit hospitals, collection agencies, or debt buyers from placing a lien or foreclosing on a patient's home to recover an unpaid medical debt. But South Dakota does have, to be fair, an unlimited homestead exception. So it allows debtors to fully shield their primary homes from creditors. But what gives? Axton, you're the finance guru here. So, I mean, how do we explain that? Why are we so behind? That's the $1 million question, right?
Yeah, I would say in a word, politics. You think of the politics of Minnesota versus South Dakota and how Minnesota has some additional protections relative to us. I think a lot of this is driven by state politics and the idea of, personal responsibility, which I realize that can be contorted and stretched in ways that it shouldn't be. But I think there's a prevailing political attitude here that has kept us from having some consumer protections that other states benefit from.
Well, in January of this year, the Consumer Finance Protection Board ruled, there was a ruling that prohibits consumer reporting agencies from including medical debt on credit reports and bans lenders from considering medical information and credit decisions. But that only applies to creditors making lending decisions. That on top of that, that's currently on hold. There's been a resolution introduced to put that on hold. So what, and to back up a little bit, the big three, Equifax, Experian, and TransUnion, all stopped doing that several years ago now, in 2022, I think. Anything over $500 can be reported, but anything under $500, they no longer report that. But
right.
What's the basis to the opposition? What's so bad about this? There's good and bad, I'm sure, but why is there opposition to such a piece of legislation that says, hey, because that, to be fair, I wouldn't say that. To me, it seems medical debt isn't a good indicator of your ability to pay your other obligations, right? Nobody plans for medical debt. So what's the basis for the opposition of that?
So I dug into this a little bit in anticipation of today's conversation, and what I found, and you don't have to dig too far to find this online, there is a concern or worldview, perhaps, that the CFPB has overstepped their regulatory authority. And so there's nothing that I can find out there that says, oh, this is bad for consumers. It's the regulatory authority of the CFPB was overstepped. That's the argument. It has nothing to do with consumer well-being. It's like at that level, consumers aren't even part of the equation in this. It's who really had the authority to make that decision.
Okay, so it's more it's not related to the best interests of the consumer. It's the business side of it. It seems to be the primary focus.
I would say it's more of a political side than a business side, I would think. Yeah.
Well, in the chat, Dell asked, where does Medicaid fit in here? And that's one of the things I had on my list to talk about. This is statewide Medicaid expansion we had in 2023. It was supposed to be a possible avenue to reducing overall healthcare costs, right? And but it's been slow to catch on. So, and that was the looser income guidelines for eligibility. What do you think needs to happen for Medicaid to become a major factor in this, or is it a major factor? How does it fit in here?
Well, from my perspective, right now, it's a very big question because we're hearing all kinds of horror stories coming out of Washington about cuts to Medicaid, even though Medicaid is even now doesn't begin to really meet all the potential needs. One misunderstanding, and I think it's still true, we assume Medicaid is a program to provide coverage for the poor, and I think it's still true. Medicaid in this state was a categorical program, meaning it no matter how poor you were, well, you got down to really incredible low levels, but if you were just poor, you didn't qualify. It covered the elderly, it covered women and children, and it covered the disabled. but if you were otherwise, you were just poor, you didn't qualify for Medicaid coverage. And another thing that bothers me, which is maybe a little off the topic, but Medicaid is a major provider for both rural hospital services and especially for nursing home services. And I think I mentioned I sit on the board of our local nursing home, and Medicaid is a major provider. And up until just a couple years ago, Medicaid refused to pay the cost of those of the residents that had Medicaid coverage. Fortunately, the legislature finally saw to it to pay their full cost. So it's been much better for the nursing home in the last year or so. But what we're hearing now, that the feds want to transfer more of the Medicaid costs to the states, and you can imagine how well that's going to, first of all the budget problems that our state has, that our legislature faced in this last session, and if they add a big increase in Medicaid, it's going to be much worse. So I don't know. That probably doesn't answer the question, but anyway.
Well, and you brought up this most recent legislative session, and that kind of brings me to, there were two bills introduced into the House, right? There was a House Bill 1058 that prohibits the reporting of medical debt to a consumer reporting agency and to provide a penalty therefore, and House Bill 1210, which prohibits a hospital from reporting medical debt for collection in certain situations. And there's a list of situations that goes with that, including, if the patient has not received an itemized statement, if they're adhering to a payment plan, they can't be turned over for collection in those situations. Unfortunately, those were both voted down. One of them didn't even make it out of committee. So I guess I'm stumped as to why those two pieces of legislation would be deemed as not a benefit, or why what's the argument against them? I guess I don't understand that. Like, are you guys familiar at all with the arguments against them? There is a comment. Mary says in the comment in the chat, our state auditor should play a crucial role in addressing medical debt by ensuring transparency in our government-sponsored health plans. She's curious about any recent actions taken in our state regarding the issues. Other states have prohibited contracts with pharmacy benefit managers, or PBMs, that utilize a spread pricing model. I'm unsure of our state's current position on this matter, but it is definitely worth investigating or requesting an audit of the pharmacy middleman. This is an important issue to look into as well. So at the state level, where are we sitting now? Do you have any idea, Axton, like what's going on legislatively, or anything that's being done in South Dakota to address medical debt? And the two things that were introduced into the legislature were shot down. So what next?
Yeah, I mean, that's a good question. What next? What are we going to do to address these problems? And at a state legislative level, are we just going to ignore it? What are we going to do? And I think that goes back to contacting your legislators to make sure that they know this is an issue, and we'd really like you to do something about this. I think having those contacts is still important. But I think it goes back to the point that I made earlier. When you're comparing South Dakota and Minnesota does have some consumer protections for medical debt that we don't have. It's a difference in politics and in worldviews, I think, between the two state legislatures.
Well, and it's surprising to me because South Dakota has an aging population. We have we have a significant proportion of the population that requires medical care. And yes, Medicare is out there, but Medicare is not going to cover everything. So I'm just kind of stumped at the whole thing. And I'm not an economics person, so I like that part of it fascinates me. So really, I do want to open it up again before we get to our final segment of the discussion for anybody who has any additional questions. I see there's one in the chat or a comment from Trish in the chat that we're going to address here in just a minute with our final section. But does anybody have any additional comments, questions, concerns about the consequences of medical debt? Okay, so we'll move on. And I'll start with Trish's comment here. Another thing that should be published more broadly is that Sanford gives everyone a prompt pay discount of 10% if you pay your entire balance, whether it's $100 or $1,000, in the same month that it was billed, but you have to ask for it. Everyone should always do that. 10% adds up, and that's actually spot on with that, because that's one of the things that the Georgetown report that I was reading about, that's one of the things that South Dakota doesn't do. Hospitals and providers are not required to share that they, the specifics of their payment plans. And like the House bill that was introduced, that would have prevented hospitals from sending to collection a person who was paying on their payment plan and was up to date on their payments, they could still send them to collection. So from an economics point of view, what can consumers do to handle medical debt? Like, what are the resources that are available? What do we do?
So Trish brings up a really good point about asking for what resources are out there from your healthcare provider. So there are, I didn't realize that discount was available through Sanford. So thank you for sharing that. But you should also ask for any financial assistance that you may be available for. For a while, when you walked into Avera, they would give you a handout for financial assistance, and you could look at the criteria. And if you met the criteria, you could fill out the form and submit it and get the financial assistance. They've stopped doing that more recently, though. I'm not sure why. I also think you should educate yourself about what your insurance actually covers. If you don't understand your insurance policy, there are accredited financial counselors available at Lutheran Social Services, as well as private accredited financial counselors that you can find an AFC at afcpe.org that can help you. And most of them will work on a sliding scale basis to help educate you on what your health insurance plan covers, and what is your deductible, what is your copay, what is your coinsurance, what is your out-of-pocket. Other things to be aware of are the Fair Debt Collection Practices Act. So if you have outstanding medical debt that has gone to collection, you need to be aware of what debt collectors can and cannot do. So the Fair Debt Collection Practices Act is a piece of federal legislation that is out there that tries to address this problem, because there's an old saying of where there's a rule, there was a problem, and debt collectors were behaving badly. And for a long time, there weren't any consequences for that. So the Fair Debt Collection Practices Act makes it illegal for debt collectors to call you at odd hours, to use obscene language, to use threatening language, to threaten physical harm, things of that nature. If you can prove that a debt collector violated this act, there is the possibility of financial remuneration for you. But outside of the financial remuneration, as a consumer, you need to be aware of what the Fair Debt Collection Practices Act covers and what your rights are with regard to engaging with debt collectors, because some of them will behave rather unscrupulously, and full well knowing that most people do not know what their rights are. You should also know that the statute of limitations to collect medical debt in the state of South Dakota is 6 years from the date of the last payment, or if there aren't any payments made, the date that was printed on the bill. So not the date that it was mailed, but the date that was printed on the bill. That's different from credit reporting. So even though that collection cannot be legally collected upon after 6 years, it's going to stay on your credit report for 7. So most folks don't realize that. They think that the 7 years on your credit report is the same for debt collection. It's not. In fact, in most states, the statute of limitations to collect on a debt that's been turned over for collection is 6 years. Some are 5, some are 7, but most are 6 years. So that is really, if you have medical debt or you're anticipating you're going to be in medical debt, in the reasonable near future, I do want to point out some ways to plan for medical debt or kind of head it off. From a financial perspective, I'm not a healthcare professional at all. Of course, stay healthy, do all the things that your doctor tells you to do, and engage in wellness care. But from a financial planning perspective, there are flex spending accounts and there are health savings accounts that are out there. Flex spending accounts, you can put up to a maximum dollar amount per year into those accounts. And in order to qualify for one, you have to have a low deductible health plan. So the money you put in there, it lowers your taxable income for that year. So depending on your income level, you could qualify for some additional tax credits if you're right on the bubble, because you're lowering that taxable income by contributing to an FSA. Same is true for an HSA. The drawback to flex spending accounts is that if you don't use the money in the account by the end of the year, so the end of your health insurance year. So for some of us, that's December 31. For others, it's June 30. That money's gone. It's gone forever. You can't get it back. A nice benefit to health savings accounts is the money you put in there. And for 2025, for single coverage, it's $4,300. For family coverage, it's $8,550. That money you put in there goes with you. It's portable. Your employer is not going to take it away from you at any point, and you can use a portion of that money for investment purposes. So it's a way to build wealth. And you can pull money out of there at any time to pay for any unexpected health expenses. That money can be used in retirement to pay for healthcare expenses tax-free as well, if you've got money in there once you retire. You do have to have a high deductible health insurance plan to qualify for an HSA, but they are a really great tool. And I think the best benefit of those is that the money never goes away. You're also lowering your pre-tax income for the year, and withdrawals on HSAs that are used to pay for medical expenses are tax-free. So just a little bit of pre-planning, I think, can go a long way. And psychologically, when it comes to money, if we can have more control over our destiny, I guess, if you want to call it that, versus giving basically all of your control to whatever your insurance company is going to pay or not pay, the more control you have, the less anxiety you're going to feel. If you give all of your control over to the health insurance company and hope they're going to have your best interests at heart, you're going to be disappointed and have a lot of anxiety.
Well, and I think that's a good thing to point out, Axton, because like we mentioned at the very beginning, the vast majority of medical debt isn't planned. It's something that happens. So, and a lot of people aren't prepared for it without this type of planning. It's not something that you necessarily want to have to think about, but especially in South Dakota with our extremely high cost of medical care, and the contributing factors to that, I think that's a really good thing to point out, is the importance of having an FSA or an HSA account. Does anybody have any more questions? Oh, I have a comment here from Mary in the chat. For someone who spends a lot of time at the Capitol during session, it's important to recognize that Avera and Sanford have a significant influence on legislative outcomes. They are often behind the scenes undermining good bills aimed at promoting transparency. When looking at the bills mentioned, it's clear that those which do not support transparency are primarily driven by lobbyists from the medical establishment. Thank you for that, Mary.
Mm-hmm.
And I think that's a big piece. I think, as with anything, as citizens, when we want to have change, I mean, you contact your legislators. Dr. Tom, do you have any thoughts on this, on what to do?
Well, my concern is that our problems are built very deeply into the model, the economic model that we use, and it kind of works against us. Our society is, first of all, is very skeptical about government programs and government intervention, and people oftentimes say, well, we don't want socialized medicine. That's the worst thing. Well, in fact, Medicare is the classic example of socialized medicine, and even though it has lots of problems, it works reasonably well. Medicare has an overhead percentage of about 2%. Private insurance overhead costs are, I don't know, anywhere from 12 to 20% or somewhere in that. It varies. So it works reasonably efficiently. There's been pushes to say Medicare for all. And to be honest, I find those increasingly appealing. There are lots of problems, but I think our fear of government intervention has worked against us, because, like I say, Medicare is reasonably efficient and reasonably effective. So anyway.
Thank you for that. Does anybody have any final thoughts, comments, opinions, concerns? Okay. Well, I don't know if there's anything else we can really add to that right now. So we might just let you get back to your what you were doing a little bit early today. I do want to invite you all back to join us again on May 8th, when we're going to be talking about the persistence and presence of Indigenous peoples, moving beyond mascots, stereotypes, and cultural appropriation. The Native American image is everywhere, right? They're everywhere and nowhere, because Native American images are on everything from motor oil to launch rocket systems. But there isn't a lot of familiarity and education and exposure to what the Native American peoples, what their culture means, what does it mean to be a Native American in this country at this time. So we're going to be joined by Dr. John Little from USD and Megan Redshirt Shaw. She's also at USD. I hope that you can join us. It's going to be an incredibly interesting conversation. I do thank you for joining us today. Thank you, Dr. Tom. Thank you, Axton. If anybody has any questions, comments, please go ahead and fill out the survey listed in the chat. And I hope I will see you again in a couple weeks. Thanks, everybody.
Thank you.